Just on the previous talk, I like to make one comment that whenever there is a PCR, I usually after putting the IOL, constrict the pupil and put the tricot once again and to check whether there is any vitreous into the anterior chamber or not, and do the final vitrectomy then. So this is just a video which is self-explanatory. इसका ऑडियो चला देना बेटा, ऑडियो चला नहीं. I think I'll then go ahead and speak. उसकी आवाज़ बंद कर दो फिर. नहीं इसकी आवाज़ I'll speak. So I'm going to talk about the hard cataract, how to operate. And you don't have to have the extra talented surgeon, but you need to understand certain basics and certain anatomical facts are to be kept in mind when you are dealing with the hard cataract. We know that the densest part is in the center and the lens is concave backwards. So I'm going to demonstrate my technique of V-trench. I like to make a little wider trench, because when you make a shallow trench, you are not able to go into the depth of the nucleus, and because the sleeve cannot get accommodated, sleeve is much wider than the tip, but cutting is done by the tip. And I usually prefer to use the chopper device by the Mohan Rajan. I prefer to use the Kelman tip, and I use a regular tip instead of a micro tip in these cases. So the V trench is like in the diagram you can see. Now when I make a trench which is wider in the periphery, and this is when I rotate, I can accommodate the sleeve, and then it is V vertically down as well. As I keep on going down, the trench becomes narrower, but it reaches to the depth. So peribulbar block has been given in this patient, and if there is any doubt, give a peribulbar block. Capsular access should be little on the larger side, that means around 5.5 millimeter, not more than 6 millimeter, definitely not less than 4.5 millimeter. And after removing the capsule, I do not do any hydro dissection at this stage, because the hard nucleus, when you do hydro and you are trying to make a trench, they keep on rotating and then you got to keep on positioning them. So start the trenching without any hydro procedure, then the nucleus is very well stable inside the eye. So go and lift, and now if you see the trench, it is not a central, it is both these trenches are slightly paracentral, which is making a pattern of V, which is much more wider at the periphery than at the center. And as you keep on going, and you can see that it is far more, now there is no rotation of the nucleus. Nucleus is absolutely stable. In harder cataract, you try to, and the nucleus keeps on rotating when you are making a trench. And now I'm not going up to the periphery, I'm just making a small central grooving more. You can see the red reflex coming from the periphery. Now I inject the viscoelastic, remove my chopper, and after nearly more than 80-90% of the trench has been made, now I do the hydrodissection to rotate the nucleus. So that way I am able to make an excellent trench. And once I rotate this nucleus, then you will find that the wider peripheral part comes sub-incisional and will be able to accommodate the sleeve of my phaco tip very well, and I'll be able to really go into the depth of the nucleus without any problem. So once you reach the depth of the nucleus, many times you will find that the nucleus, you have gone to the depth of the nucleus, but there is a posterior leathery plate which does not gives way, and we try to crack it over here, and but the posterior leathery plate is holding on. So the best way is, now what I'll do that, I'll hold one end of the one heminucleus with the highest vacuum available on a machine, which is 600, and with the chopper I will do the radial split. Instead of having a central split pulling lot of fibers in one go, just at the one end you hold with a vacuum setting. At this time there is no danger of the PC or the capsule, because the whatever may be the vacuum, the tip is absolutely closed, there is no such nothing. And you can see now the fibers split one by one, instead of all the fibers when you try to split from the center, and you can see this slit has gone up to the center. Now I leave this end and rotate the nucleus and repeat the same thing, holding the another heminucleus from the another end and split it up, going up to the center. So this again, and this first split is the most important split in a hard cataract. If you can get this split, then rest of the job is far more easier. But if the leathery fibers are attached, then when you try to take out the any hemifragment, it is not coming, you get irritated, you damage the capsular axis with the sharp chopper, and everything becomes very, very difficult. And once this has been achieved, then rest of the surgery is far more easier. And I keep the vacuum settings high, around 600, 650, and use the regular tip so that you have got a good hold, and divide this into as small pieces as possible. Each heminucleus maybe into 4, 5, 3, whatever maximum you can do, and try to make the split goes up to the center. You can keep on removing them one by one, or you can chop them and then remove all of them together. So again you hold it over there and split it, and again see that the split is in the radial direction. Keep on repositioning your chopper. Your chopper has to be very close to the fibers you want to split. It should not be at the periphery. So again and again reposition your chopper, split it, separate sideways, keep on separating sideways, keep on separating sideways, and once you get fibers gone up to the center, then remove this piece. And the first half of the nucleus, my vacuum settings are very high, because as long as some of the nuclear fragment is in the capsular fornices, in the capsular bag, the chances of posterior capsule coming forward are much less. As soon as your bag becomes empty, that is the time when the capsule comes forward. So in the first half of the nucleus, you can actually go at a 600 vacuum settings without any danger to the posterior capsule at all, and this will reduce the danger to the cornea if your vacuum settings are high, because when the vacuum settings are low, the pieces keep on roaming around here and there, and you are not able to chop it so well, and you damage cornea more. In a higher setting, actually you will be able to suck the pieces closer and will use much less phaco energy. Again you can see that I am rotating them instead of pulling them sideways. And once my nearly 3/4 of the nucleus is gone, when I feel now the posterior capsule will have a tendency to come forward, now my vacuum setting will go down. So from 600 I go down to 500, and the chopper also, after chopping the last fragment, I'll prefer to change my chopper to, instead of sharp and a big chopper, I put on a viscoelastic, and then I take the, now it's not a sharp and a long chopper, I've taken a little shorter chopper now because I don't want to damage. I put on a viscoelastic to prevent the capsule coming forward. I have lowered the vacuum setting, and now at this stage the vacuum setting, when the last fragment is there, the vacuum setting is of 400, not even 500, and this may be little more anterior as compared to the earlier fragments, because I really definitely want to prevent the damage to the posterior capsule. And many a times when I am removing the last fragment, I remove the chopper from the side port to avoid the leakage from the side port. So this way you can see that the nice rexus and the well-positioned lens, and usually these patients will have clear cornea next day if you follow the basic principles of doing heart cath. Thank you very much for your kind attention.